Hello everyone, my name is Mike McKenzie. I'm a registered respiratory therapist and instructor in the respiratory therapy program. What we're going to do today is a follow-along demonstration of a respiratory assessment of a critical care patient in an intensive care unit. Before we introduce ourselves to the patient, we're going to do an initial impression to have a look at the patient, see if there's any general issues happening that we need to intervene with immediately. Currently, I see a patient with their eyes closed, sedated. I can see chest rise with assisted breathing done by the mechanical ventilator. A quick look at the screen in the mechanical ventilator shows that we see safe parameters in terms of ventilation. And next I want to look at the vital signs to ensure that we have a heart rate, a good oxygen saturation, and a good blood pressure. Overall, it's relatively safe and stable, and we can proceed with the assessment. Hello, Stephen. My name is Mike McKenzie. I'm a respiratory therapist. I'm going to perform a patient assessment on you right now to see how you're doing on this mechanical ventilator. One of the non-patient assessments we do in the ICU is a check of our safety equipment. We want to ensure that our suction is set to a proper pressure and that it's ready to go in case we need to suction at a moment's notice for our patient. Since our patient is on a mechanical ventilator, we want to ensure that our suction is set up and with an inline suction for our endotracheal tube. The other aspect of the non-patient assessment is to check our manual resuscitator. Manual resuscitator is used to manually ventilate or breathe for the patient when they're not on a mechanical ventilator. And that could be to troubleshoot the ventilator or to troubleshoot an issue with the patient themselves. Ensure that you do a full check of your manual resuscitator prior to beginning your assessment with your patient. Now that we introduced ourselves to the patient, we're going to perform our respiratory assessment. Respiratory assessment includes the inspection, the palpation, percussion, and auscultation of our patient. So the first thing we're going to start with is an inspection of our patient. We're going to lower down the blanket, letting the patient know what we're doing. We're going to undo their gown, have a look at their thorax. From here, I'm going to inspect the patient's breathing, take a look at their facial expressions, take a look at the endotracheal tube. Take a quick look at the extremities to notice things for any pedal edema or any deformations to the feet that may be associated with any cardiovascular issues. We want to inspect his endotracheal tube. We want to inspect the size of the endotracheal tube, where it is at the teeth, and we want to move the endotracheal tube to ensure that we can complete mouth care. Other reasons to move the endotracheal tube is to ensure that no breakdown of tissue can occur to reduce that risk. We're going to inspect the mouth to see if there is any tissue breakdown occurring. When we complete this, we do want to check with our monitoring record to ensure that the patient still has the endotracheal tube at the same placement at the teeth that they were last checked. What size of endotracheal tube did you note on your patient? What was the depth at the teeth? Did it match the monitoring record of the last check of your patient? Was there any skin breakdown around the mouth, tongue, or any issues with the teeth? We moved the patient's endotracheal tube from the right side of the mouth to the left. The endotracheal tube should be moved at least once every shift to help reduce the risk of breakdown of tissue around the mouth. After the inspection is complete, we're going to palpate or touch our patient to see if there's any deformities, contusions, abrasions, any atypical findings that we may find across the thorax. We're going to start on one side and feel the bony structures, and then we're going to compare it to the opposite side. We're going to move down the ribs and feel the ribs, and then compare it to the opposite side. While we're doing this, we're going to take a look at the patient to see if there's any facial grimaces occurring or any issues along with that associate with pain or discomfort while palpating the patient. When we're finished, we'll palpate the sternum. Next, we're going to palpate the soft tissue. We can examine the neck to see if there's any jugular vein distension, and we're going to feel across the neck for the sternocleidomastoid mastoid. And from here, we'll feel the soft tissue of the patient. Comparing each side from the last. What we're going to do next is we're going to auscultate the patient. When we auscultate, we'll listen to one side of the lungs and compare it to the next. Remember, after auscultation, if you heard coarse crackles within the lungs, that's an indication to suction. At this point in time, we will stop our assessment and intervene and suction our patient. When we suction our patient, we should take note of the amount of the secretions, the thickness or tenacity of the secretions, and the color of the secretion. After we perform our suction, we should re-listen to the patient to see if we hear any improvements to their lung sounds. If we think we need to do another pass of the suction, we'll perform another suction and then once again reassess by auscultating to listen to see if any changes were made. After you auscultated, what did you hear? Were the sounds symmetrical on each side, or did you hear different breath sounds? If you heard different breath sounds, we'll move on to the percussion aspect of the assessment. When we perform percussion, we compare one side of the body to the last, much like every aspect of the patient assessment. When we percuss in the same areas that we listened while we auscultated the patient. When you performed your percussion on the patient, did you notice any differences in the sound? Percussion allows us to assess the lung density. If we hear dull sounds performing percussion, it can indicate consolidation within the lung. A hyperresonant sound, much like the sound of hitting snare drum, can indicate an overinflation of the lung. What were your findings on percussion? We performed a patient assessment on the anterior aspect of the patient. We should perform a posterior patient assessment as well. It can be difficult to do this in the ICU due to the sedation of the patient and the equipment and lines that are attached to the patient. If you do have help, other healthcare professionals can help you to reposition the patient, to auscultate, inspect, palpate, and percuss the posterior aspect of the lung field. If the patient has any lines in for medications, fluids, or to monitor things like blood pressure, we want to inspect the insertion to ensure there's no irritation. If the patient has an arterial line in, inspect the insertion site for any irritation. Was there any irritation at the arterial line site? Do you have a proper waveform on your monitor? After we completed our patient assessment, we're going to move our attention towards the mechanical ventilator. What we want to witness or observe on the mechanical ventilator are our peak pressures, our mean airway pressure, our set PEEP and our delivered PEEP, and our tidal volumes. Our peak pressures are greater than 30 centimeters of water pressure. On our flow waveform, we do not reach equilibrium where the flow does not reach baseline before exhalation. Because of this, we should do a static measurement of our plateau pressures to ensure that our plateau pressures are less than 30 centimeters of water pressure. Ensure that we're safely ventilating our patient. Our plateau pressures are at 24 centimeters of water pressure, a safe pressure within the alveoli. What were your peak pressures, your mean airway pressures, your set and measured PEEP, your set and measured tidal volumes? Were your peak pressures high? Does your flow waveform reach equilibrium? Did you do a static hold and measure your plateau pressure? Was your plateau pressure less than 30 centimeters of water pressure? Next, we want to move on to our waveforms. We want to review the pressure waveform, the flow waveform, and the volume waveform. What did you observe on your ventilator? Did the waveform show any abnormalities, like indrawing on the pressure or peaks? Did the flow waveform reach equilibrium? And on the exhalation aspect, did it reach baseline? Could there potentially be air trapping? If so, you could do an expiratory hold and measure the total PEEP to measure the intrinsic PEEP or any air trapping in the patient. Does your volume reach baseline or zero on exhalation? If not, is there a leak? Ensure to review your patient monitoring record of the mechanical ventilator. Your findings and observations during your inspection, do they match what was previously written? If there are changes, ensure you note them. When filling out your patient monitoring record, ensure to fill out every aspect of the mechanical ventilator. Tracking and trending your information will give us great detail about the patient's condition, if they're getting worse, or if the condition is resolving. And it allows other respiratory therapists to see what was done in the past, how it worked, and help them plan their treatments for the future. To summarize what we did today is we performed a respiratory assessment on a critical care patient in the intensive care unit. We started with our initial impression and gained information about the patient's status and if they're safe. We performed a non-patient assessment on our suction and our manual resuscitator. Then we performed our patient assessment, including an inspection, palpation, auscultation, and percussion. What were your findings on that assessment? Ensure you write them down for your patient care record. After our patient assessment, we checked the lines to ensure there's no irritation, and then we moved our attention to the mechanical ventilator. We were effectively ventilating our patient in a safe manner. What were your observations on your mechanical ventilator? After we do our mechanical ventilator checks to ensure safe ventilation, we record our data. We compare our data to the past trends to ensure any changes are observed for the patient. After our patient assessment and our assessment of the mechanical ventilator, we want to ensure that we observe and monitor any changes or trends to the mechanical ventilator. After that, we're going to perform an arterial blood gas analysis. If there is any abnormal findings on our blood gas, we can make changes to our mechanical ventilator to optimize ventilation and oxygenation. After you analyze your arterial blood gas and make changes to your mechanical ventilator, make sure you document everything that has been performed. When you're at the end of your shift, make sure you collect all changes and assessment findings that were performed and create a concise and precise report for the oncoming RT at shift change.